Hello, my name is Ruben Mesa, and I'm the Executive Director of the Mays Cancer Center at UT Health San Antonio, MD Anderson. And it was very exciting to be both one of the co-chairs and actively involved with this year's European School of Hematology MPN and CML Practical Management meeting, which we held at the end of February. I wanted to address today, there were so many wonderful discussions, interesting things going on, but I wanted to tackle the issue of what are some of the promising agents in myelofibrosis, because I'm deeply excited about the pipeline of new therapies for our patients. So at the current state, we have both ruxolitinib and fedratinib, both very good JAK2 inhibitors. Ruxolitinib, which we've used for many years, fedratinib more recent on the market in the US and now in Europe, Israel, and other countries. But there's a strong pipeline behind those agents to help us flesh out options for our MPN patients. So first, I would say two other JAK inhibitors that are very mature in their development and likely to become approved. Momelotinib, which is also a ACVR1 inhibitor, inhibits hepcidin, improves anemia, and is currently in the MOMENTUM study that Dr. Verstachuk and I are leading for individuals with difficult MF, failed ruxolitinib, have lots of symptoms and anemia, randomized trial versus danazol. Second, pacritinib. Pacritinib, very active in the myelodepleted phenotype, patients with low platelet counts, and still having benefits of improvements in spleen, symptoms, and other difficulties. So both these agents might really complement our options significantly. Then there's several additional agents, two that have been both active in combination in the front line and in the second line. The one with the most mature data is from Constellation, CPI 0610, together with ruxolitinib, showing some impressive phase 2 initial response rates, but also showing activity when added on to Rux and suboptimal responders, as well as in the second line setting. So that's an exciting drug, expanding the benefits, some improvements in fibrosis, perhaps allele burden, cytopenias. Navitoclax, working through BCL XL pathway and the apoptosis pathway. Combination data upcoming in terms of frontline with Rux. Second line add-on data where data has been reported, good responses for individuals that were having a suboptimal response already to Rux. Then there are agents that are being looked at in the single line setting. There is imetelstat that now is opening into a phase 3 trial, looking for a survival advantage, one of the first drugs to look at that in that sort of setting, coming off of some of the analysis of the phase 2 study, showing that higher doses of that agent have an improvement in survival for patients with MF. Perhaps less dependent on improvements in splenomegaly and symptoms, maybe working through different mechanisms of action, with its telomerase inhibition. There is also IMG 7289, both in MF and ET. I've been involved with both of those studies. A good drug, LSD1 inhibitor, bomedemstat is its name, showing good activity in the second line in both diseases. Finally, there's also luspatercept, that is a TGF-beta ligand trap. It is approved for MDS as well as for hemoglobinopathies. Active alone or in combination for myelofibrosis might be very helpful for anemia. There are many other drugs in the pipeline. The MDM2 inhibitor from Kartos, ropegulated interferon may have a role in myelofibrosis, amongst many other agents. But as you can see, it's a very robust pipeline, probably wind up to expand to impact other patients with MPNs, MPN, MDS overlap patients, and who knows where it goes from there, but excited about these options and excited to get them to our patients who need help with their difficult disease. Thank you.